Dear colleagues, in partnership with NDT, Nephrology Dialysis Transplantation, the official journal of the European Renal Association, MARKUS at Home welcomes Dr. Martin Windpessl in Wels, Professor Andreas Kronbichler in Innsbruck, in order to discuss how to prevent infectious diseases in patients with glomerular disease who are on immunosuppression. Dear Dr. Windpessl, thanks for accepting our invitation. And dear Andreas, thanks for switching sides today and for being our expert, although I'm looking forward to having you back as co-moderator in the next weeks. Andreas Kronbichler is a nephrologist in Innsbruck, Austria, and assistant professor at the Medical University of Innsbruck, and Martin Windpessl is a nephrologist in Wels, Upper Austria. He is first author of the recent NDT paper, Preventing Infections in Immunocompromised Patients with Kidney Disease, Vaccines and Antimicrobial Prophylaxis, with Dr. Kronbichler as last author. After Andreas switched sides tonight, I am honored to have two renowned co-moderators, Professor Hans-Joachim Anders from Munich, Germany, world-leading expert on autoimmune kidney disease and NDT's editor-in-chief, and Dr. Hanna Kaminski, who is a nephrologist at the Centre Hospitalier Universitaire at Bordeaux, France. She leads the European HORUS project, which aims to improve the treatment of CMV infections in transplant recipients. Both Professor Anders and Dr. Kaminski have been our experts in earlier MARKUS at Home discussions, and we are happy to have the two of you back tonight. And before passing the microphone to Andreas Kronbichler, Professor Anders will introduce the academic cooperation between NDT and MARKUS at Home, which starts today.
Yes, thanks for the kind words. Hello, everyone. Yeah, today I'm here as responsible for NDT, and we try to enhance the dissemination of our content to spread the information our authors provide in their publications. We are active on social media. We fuel into several interview and video formats, and as a new collaboration, we get a slot once a month, thanks to Gunnar Heine in MARKUS at Home. So this is a long format, is a 1 hour discussion format, quite unusual nowadays, but obviously extremely successful. And we are very happy to get the opportunity to have selected papers presented here and discussed here. And this is fully in line with the mission of NDT to make a contribution to the community and to enhance the discussion, the progress for our kidney patients. So thanks again for this opportunity, and I'm looking forward for today's presentation and discussion.
Yeah, it's a great pleasure for us to present our recent publication from NDT as the first shared NDT MARKUS at Home collaboration. And clearly our aim was not to replicate what has been published before, and we didn't focus on COVID-19 at all in our review, and we didn't really tackle dialysis patients, and also not really focused on transplant patients, but wanted to provide a picture that there is a paucity of data in most of the infectious diseases we are seeing in, for instance, transplant patients, but there is really no good evidence for patients with glomerular diseases. And that's of course, a huge unmet need. So Achim and Stephanie Steiger and others have come up with a new form of immunodeficiency. And I think this is very, very important if we talk about infectious disease and preventing it, because of course all of our patients with kidney diseases are in a form already immunosuppressed and are vulnerable populations, and we know that immunodeficiency is manifold and can happen to do treatments, but also of course to do of comorbidities of our patients, which are quite common, such as tuberculosis, dysbiosis, malnutrition, and others. Clearly, what we know is that the infection risk of this patient population is pretty high. And one of the drivers of infections is, of course, the high doses of steroids we are using, especially in the initial phase. So that means that the infection risk is highest, of course, during the first 6 months, while we consider this as the induction phase of therapy in most glomerular diseases. And this has been highlighted here quite nicely in rheumatology, showing that if you use higher doses of steroids, such as in the low-dose high dose or in the Bexivir standard dose group, you see more infectious diseases. And this has been significantly reduced by using either a low dose in Bexivir or reduced dose in lowers without losing actually efficacy. So a lower dose of steroids is as effective as a higher dose of steroids in terms of remission rates, but can significantly reduce the burden of severe infections. This has also been highlighted here, showing that patients with glomerular diseases, either in a pediatric setting or in an adult setting, have a markedly increased risk of severe infections in comparison to the general population, as outlined on the left-hand side. And this is to an extent as seen as patients with CKD4, for instance. So this is from our recent paper, and we highlighted risk factors for the different infectious diseases. And as mentioned initially, there is a low evidence base for all of these risk factors, which have been posed by single studies mainly. For CMV and for herpes zoster, it's likely that higher doses of steroids are risk factors. For influenza, it's not well established. For Hep B, it's clearly to do with reactivation, and we will come back to that later. For pneumocystis, we have better evidence base, especially for vasculitis patients, but it's lacking in other diseases, mainly except of IgA nephropathy in the Chinese population. And for Streptococcus pneumonia, it's clearly also not really well established so far.
Thanks, Andreas. Basically, we know prevention is better than cure, and three key strategies exist to mitigate the risk of infection. Number one being antimicrobial prophylaxis, number two, preemptive therapy, and the third, and arguably most important or most effective means to decrease infectious risk are vaccines. And at this point, it is perhaps important to note that the WHO noted that vaccine hesitancy is a major threat to global health well before COVID-19 hit off, calling it a major threat to global health. Apart from true reluctance and flat refusal, there are also logistic hurdles in the implementation of widespread vaccination of patients at risk. These hurdles can be logistic. They can be basically finding out who is in charge, primary care providers, specialists like nephrologists like us, and also financial hurdles. New drugs are costly, well in the hundreds of euros. And this summer in our hospital, we have established, in collaboration with our Department of Microbiology, a clinic where we try to close vaccine gaps and send patients with CKD facing immunosuppressive therapy like membranous nephropathy patients in clinic to address vaccines they might need. When planning the article, there was considerable discussion which pathogens should be covered in our review and to what extent. And in the end, we decided to focus on 6 major pathogens, 4 viral, 1 fungal pathogen, and pneumococci, somewhat arbitrarily, but I think these are important pathogens, and obviously there were limitations and constraints in space in the journal. We also decided to present the various pathogens not in a strictly similar fashion, but to remain rather short in cases where recommendations are straightforward, such as influenza. Obviously, all patients with CKD should get their yearly influenza vaccination and their relatives of note, and therefore digging deeper into areas where there is little or less evidence, bearing in mind that we might not be able to issue clear recommendations. We did not discuss more exotic pathogens, but given NDT's global remit, we decided to give recommendations for mycobacterial infection in a table. Hepatitis B is an important pathogen and mainly associated or best known for its association with rituximab. B-cell depletion has been around since the 2000s, initially in hematology and rheumatology, and it was 2002 when the Rimuzzi paper was published in The Lancet about its successful use in membranous nephropathy. And ever since, this has been a success story, and it's used in many autoimmune conditions, renal conditions, in the field of nephrology, predominantly off-label. But it is important to note that it carries a very high risk of hepatitis B reactivation, which can result in liver failure and even death. This does not only apply to patients positive for the surface antigen, but also for patients with antibodies for the core antigen, i.e. Patients with a history of previous hepatitis B. And with many new B-cell depleting agents, for instance, obinutuzumab in lupus nephritis, it is extremely important to screen all individuals facing immunosuppression for hepatitis B. And it's not only B-cell depletion. Obviously, there are recommendations to give preventive therapy also in patients facing intense glucocorticoid therapy or likewise cyclophosphamide. And in cases there has been previous exposure, to start preemptive therapy, ideally 1 week before rituximab is initiated. In 2013, the FDA issued a black box warning to that effect, so that is 10 years ago. However, this case report from the MD Anderson Cancer Unit was published in 2021 in The Lancet, describing a man, 70-year-old with CLL, who received rituximab as part of his leukemia treatment, and he developed hepatitis B reactivation. I think this case clearly illustrates that despite its long-term record and clear warning, these recommendations are not always heeded. And as nephrologists, we certainly have less experience with rituximab in comparison to oncologists. So this is important, and we need to bear this in mind. And in case we decide to start preemptive therapy, if there is previous exposure to hepatitis B, it is perhaps prudent to liaise closely with hepatologists, because antiviral therapy changes over time, new resistances develop. So I think if you have access to hepatology or infectious disease specialist, that's the way to go. Respiratory infections are a substantial proportion of infectious complications in all patients, and therefore with CKD, and therefore it comes as no surprise that major authorities such as CDC and KDIGO recommend pneumococcal vaccination basically for all patients with CKD, which are, as we know, immunocompromised. This looks pretty straightforward at first glance, but in daily practice for non-ID specialists, it is perhaps less easy to implement these recommendations in clinic, because there are various substances with several serotypes, with covering different types of pathogens, and there are recommendations to sequential therapies with various intervals. Also, international recommendations vary. The CDC recommends giving conjugate vaccines, either PCV 15 or 20 initially, and only to give the polysaccharide in cases of PC15, whereas the authors in UpToDate argue that PCV20, although covering more pathogens or serotypes than PCV13 or 15, still misses out on 3 relevant pathogens highlighted in red. So there is a case can be made for following up the prime vaccination with subsequent vaccination 8 weeks later. And this brings us to the next slide. This is basically the Austrian recommendations published a week ago. And this is perhaps very convenient because it's less complicated. So high-risk patients, and this includes all patients with CKD, should either receive the 50-valent conjugate vaccine or the 20-valent, followed up 8 weeks later, more than 8 weeks later, by the polysaccharide. And for me, this made it easier because I think if 8 weeks is a fairly long time, and if this patient has received rituximab in between, it's not very likely that there will be substantial response to this treatment. But still, if he has received a PCV20, that's the main and effective treatment. And PCV13, the previous agent, was shown in the CAPITA study to curb on infectious risk, as published in the New England 2015. However, this study did not include immunocompromised patients. Another more innovative concept was published or presented, it was only an abstract, by the French vasculitis group, Benjamin Thierrier and colleagues, and they introduced the concept of reinforced vaccination. Basically, this included patients with ANCA-associated vasculitis being treated with rituximab, and various vaccination schedules were tried, and the one where PCV13 was given within 1 week apart, followed up 5 months later with the polysaccharide, yielded the highest titers. Obviously, we have to say this is only a surrogate endpoint, and we have no data whether this also impacts on infectious diseases.
Yeah, maybe we could have some question at this point before, but I'd like to ask Frau Kaminski, you want to have something?
Yes, thank you very much for this first talk. I was wondering if you can say some words about for hepatitis B vaccination or a screening for the risk of reactivation for other new immunotherapy targeting the B cell or plasma cell, for example, daratumumab or some other new immunotherapy. Do you have a recommendation for those new drugs?
Well, basically, as far as I know, daratumumab, the same recommendations apply, but the problem is if the patients haven't received hepatitis B, the schedule is very complicated and long. So during active treatment, if the patients haven't received hepatitis B vaccines before, they are very unlikely to respond as far as I could consider. But this is something we should ask our colleagues from hematology, who certainly have most experience with this. But if patients have previous history of hepatitis B, I think preemptive therapy or prophylaxis is prudent to avoid reactivation.
Yeah, so this is also my question. I think we all encounter this in the clinics, that the timing with the vaccines is a problem. If you get a patient with an acute ANCA vasculitis, you wait the biopsy or something, and then you want to start treatment. So how do you do that? What is your experience? How to go with the timing? Because I think we all understood in the pandemic that after rituximab, it's very difficult to mount an immune response to something that the immune system doesn't know yet.
This is true, and I think it doesn't make much sense to give pneumococcal vaccine 1 week after rituximab, and obviously there is an urgent start and steroids are high in the first week. So I think the important thing is not to forget vaccination, and I think perhaps it's good enough to remember to cover these holes after 4 or 5 months, just before maintenance therapy starts. That's something of my takeaway lessons from preparing this review and also this talk.
Well, my takeaway is to reduce steroids, because I understood they are the main problem and they are anyway high in the beginning, right? And if we cannot vaccinate in that phase, it doesn't, I mean, it won't have this strong effect if we do it later when the steroids are low. So I think that's important, that we try to reduce steroids nowadays wherever possible. I have another question on the B cells. You mentioned the B cell targeting therapies are a problem because obviously B cells are important antigen presenting cells that are needed to mount immune responses, vaccine responses. Rituximab is one thing. Obinutuzumab, you mentioned, is coming maybe for lupus nephritis. Some people even use CAR T cells now. Probably they check everyone before and would not consider patients with hepatitis B. But how about belimumab? We are now continuously discussing to use belimumab for patients with lupus nephritis. This is not a B cell depleter, but it's a B cell deactivator. How you consider vaccine regimes in patients on belimumab?
To the best of my understanding, belimumab has not this profound effects that vaccines are not effective. So I think you can, even under belimumab, expect that there is at least a bit of a response to your vaccine. So I think this is a bit of different story, as you already alluded to, as it has a different way of effectiveness on the immune system. So yeah, I think vaccination does make sense once you initiate belimumab.
What do you do in Munich with your patients, Achim? With the lupus patients?
Yeah, I mean, we are very keen on vaccination, but we have not yet used so much belimumab for patients with acute lupus nephritis. I had treated patients with non-renal lupus in the past 10 years with belimumab, more in a kind of maintenance sort of or general lupus therapy, which does not go together with high-dose steroids and cyclophosphamide or these kind of things. So I think there it was less of a concern. But now with lupus nephritis, where it comes together with methylprednisolone, bolus, you know, with maybe cyclophosphamide, high-dose MMF, it may be a different story. But I think we learned in the pandemic, belimumab was no problem with the corona vaccine, so it may make a difference whether you deplete B cells or you only deactivate them. And from that perspective, I think belimumab may be attractive in terms of infection risk. Let's see how it goes with the new B cell depleters. Yalanumab will be a B cell depleter, and there are other B cell depleters coming. They are obviously highly effective, but they may come together with some risk or vaccine issues. So from that perspective.
Yeah, I think you're completely right. I also guess that we will see obinutuzumab in other indications as well. I guess the membranous nephropathy trial will also be positive. So it's certainly much more potent. So we probably do see a longer period where patients are not very well responding to our vaccination. That might become a huge issue in the future, I think.
I mean, if we get more potent drugs, maybe this allows us to further reduce steroid use.
That's true.
To use the use of MMF or other immunosuppressants that are part of this combination protocol. So I think gaining efficacy may offer also reducing some of the drugs that make us problems in terms of safety. So,
but in AIV, you know, steroid-free remission is certainly reality. And still, you know, what you need to do is to redose rituximab. That's the most important thing. But then you can't really expect that during a treatment cycle, your patient is responding well to vaccination. That's, I think, the main issue here. And that will be the same if you use obinutuzumab. I think you will need to give it in most patients repetitively. And I guess
Andreas mentioned in the very beginning the role of CKD. So when we think of lupus nephritis, frequently these are young females where the impaired kidney function is not yet a problem. But if we think of ANCA vasculitis patients, frequently older people that have a significant degree of renal function impairment, do you think this is a major contributor to also the infectious complications? I don't think we see the same in young lupus patients. So is it all about the drugs, or maybe it's also about kidney failure or kidney dysfunction in that setting?
Well, I think, you know, CKD in AAV with renal impairment contributes massively to infectious disease. So there are very good studies showing that if you have a GFR below 30, your risk goes up incredibly. And the same is also true for instance, cardiovascular disease, then also, contributing further to the risk or vulnerability to develop infections. So I think this is really a vicious circle here. And I'm not so worried about infections in severe infections in those with lupus, because as you mentioned, they certainly don't really have CKD in the initial phase. But in AAV, that's a massive problem, especially in the first 6 months.
So if you, if you believe what you just said, wouldn't that be a good reason in patients that have a progressive decline in GFR? So now we speak about slopes, like IgA nephropathy or other diseases, to make sure they get all the vaccines, let's say at CKD stage 2, G2 or 3A, to make sure that when a couple of years later, when they are 3B or 4, where then vaccines and infection risk is higher and vaccine response get more difficult, that they have already the primary vaccines all done. So could that be an argument to say we should early CKD patients with a progressive kind of disease to make sure they get all the vaccines early, because then later get it more and more difficult?
Yeah, that's certainly, when Martin mentioned they have a infection preventive clinic, that's perfect. We don't have that. So I think you made the point that this is really needed in future, and we also need to discuss that with the patient. And in diseases where you don't necessarily initiate, high dose of immunosuppression initially, I think it makes perfect sense to vaccinate them early on, especially in IgA nephropathy. In ANCA vasculitis, as you mentioned, you need to treat these patients immediately, and you can't really wait until they have a response to, any vaccine. But I agree with you. The earlier you can vaccinate these patients, the better probably the response to these vaccines is, and the better basically their preventive strategy is then in future.
Okay, Mrs. Kaminsky, you have a question? Otherwise, I think we let them go on, or we go on discussing.
No, we can discuss later on other topics.
Perfect. Yeah, so we also wanted to touch upon meningococcal disease, and especially because, as you all are aware of, there is a paucity of complement inhibitors coming up. And we know from the original ones, so eculizumab and now ravulizumab, so C5 blockers, that there is a risk that these patients develop meningococcal disease. And of course, it's necessary to vaccinate these patients initially. And for the initial time, you would also need to give them antibiotic prophylaxis. And then usually after 2 to 4 weeks, you stop the antibiotic because you think that these patients are responding to the vaccine. But what has become more prominent in the literature is that there is some form of a breakthrough infection. And that also argues that some of these patients at least are not responding to the vaccine as they should, and then develop a very severe meningococcal disease, despite being formally vaccinated. So here is from a recent NDT publication as well, is an overview of the pipeline of complement inhibitors. And this is basically growing every week. And we see that there are plenty of new substances coming to the market. And except of ravulizumab and eculizumab, avacopan hit the market last year. And it's important to mention that this is a different drug. It inhibits the C5a receptor 1. And importantly, it's marketed that you don't need to vaccinate your patient against meningococcal disease. And that's because C5a is very critical to propagate the infection and the severity of meningococcal disease. So it seems that the risk to develop meningococcal disease with avacopan is pretty low, and it's pretty safe to use it without antibiotic prophylaxis or vaccination. It's also important to mention that the infectious disease doctors at least do initiate the discussion that once we are bringing new drugs to the market and also trying to market these drugs, that there needs to be standardized and a very good reporting of infectious complications, so that we see that these drugs coming to the market are safe to use, and we don't need to consider a disaster in real life that these drugs are actually increasing infectious risk. So CMV is certainly something well studied in kidney transplantation especially, but really there is not a lot of good data in patients with glomerular diseases. Most experience stems from SLE cohorts, and CMV occurs when these patients are over-immunosuppressed. And of course, flares are also associated with an increased risk of thromboembolic complications. But it has been shown in AAV especially that CMV or latent CMV infections are associated with thromboembolic complications. Tissue invasive disease can occur even in the absence of a positive serum PCR, especially when CMV infects the gastroenteral tract disease. So in Bexivus, for instance, so a key study in AAV, there were a couple of CMV, duodenal and gastrointestinal infections, and we clearly need to report that more frequently in our studies of GN and especially severely impaired kidney function. The seroprevalence, as highlighted here, for instance, in Germany, is pretty high with over 50% infected in the different time frames over the years. And there is a very limited amount of publications showing that CMV prophylaxis has been given to patients with GN and, for instance, renal vasculitis, especially in the context of induction therapy. And one of the issues here is, as we are seeing that in transplant patients, that they receive a lot of immunosuppressants, which potently reduce white blood cell count. And of course, CMV prophylaxis would also contribute to that issue further. So heading over to one of the key problems we saw over the last decades, that's pneumocystis cerevisiae pneumonia, a very relevant opportunistic pathogen. And this is a study from the early European Vasculitis Society group, lumping together data from 4 different clinical trials. And what you can see here is that the infectious risk is especially high during the first year, with a mortality rate of around 50% because of infections, and BCP here contributes significantly to this issue. And then I will head over to Martin again.
Well, basically the recommendations regarding pneumocystis are at first glance straightforward. Prophylaxis is clearly recommended for the induction phase in ANCA-associated vasculitis. And somewhat surprisingly, SLE seems to confer a smaller risk of pneumocystis disease, and the risk-benefit ratio of universal prophylaxis is less clear. On the other hand, guidelines advocate prophylaxis if steroids are used for more than 4 weeks at a daily dose of above more than 20 milligrams per day, and many patients get this. Now, if we look at cohorts like minimal change patients, they, at least in our country, and I think it's similar in Germany, don't necessarily routinely get PJP prophylaxis. You could argue, well, these patients are younger and face perhaps a smaller risk of infectious diseases. But on the other extreme, giant cell arthritis, high-dose steroids for a long time, again, well above 20 milligrams at the outset, still face small or surprisingly small risk of pneumocystis disease, as shown by several American publications being published in the last years. Lastly, and this is disturbing, IgA nephropathy, we all know testing trial was kind of stopped in between and restarted after some changes have been made, including universal pneumocystis prophylaxis. So, and that's why this picture of this MC Escher staircase is here on this slide. At first glance, everything seems to make sense, but on closer inspection, things don't really fit together, and what could actually account for this discrepancy. I found this letter in this year's May issue of Kidney International very interesting. The authors addressed the authors of the Navigard trial and argue that there might be a genetic predisposition for individuals with IgA nephropathy carrying some risk alleles, which might render them more susceptible for especially fungal infections. And CARD9 might vary over the different ethnicities. It is certainly fairly high in the Chinese population, which, as we know, was the population predominant in testing trial. And CARD9 was actually initially shown in a New England paper 15 or 13 years ago in a large Iranian family where a homozygous CARD9 mutation brought an increased risk of fungal infection with severe causes. So there might be an important genetic predisposition accounting at least for a part of these variation in risk of pneumocystis disease. And the authors, Brett Rovin and Jonathan Barrett, replied by making a case theoretically of genetic screening before instituting steroids in patients with IgA nephropathy. I mean, this is science fiction at present, but a case could be made for this. I found this very interesting. To conclude, and this is, I think, a fairly well-balanced statement, we try to be not too strict because I think we can't. We wouldn't give patients with membranous nephropathy only TMP SMX, but I think if comorbidities accumulate, especially in multisystem pulmonary renal presentations, concomitant immunosuppression, lymphopenia, and especially, again, steroids, one is well advised to prescribe prophylaxis liberally.
Zoster is also a big issue in our patient population, and of course with a new vaccine which is safe to use, Shingrix, this has of course changed and the perspective is much clearer. And while preparing this article, I was really struck by one study published even in 2005 from the original WICHET trial. That was a trial comparing etanercept against placebo in addition to standard of care for the maintenance of remission in AAV. And they have reported that a significant proportion of the patients, even before going into the trial, had herpes zoster. And during the conduct of the trial, 10% of the AAV population developed herpes zoster. And the next part which struck me was that this was really independent of immunosuppression, because in the initial phase, the frequency was quite low, but after a median of around 18 months, actually, most of these have occurred. And so this argues clearly that zoster is a problem, not really during the phases of very intense immunosuppression, but in the long run. And this here, as mentioned in the slide, is a recent study on anifrolumab tested in lupus nephritis. And again, the numbers are really, really high, 16.7 in the anifrolumab group, and in the placebo group, 8.2%. And this clear signal was also seen in the non-lupus nephritis trial. But this is important, the numbers were massively lower. So they were like 6% in the anifrolumab group and 3% in the placebo group, arguing that our patients with renal involvement, even though the GFR is preserved, but they still have a massively increased risk to develop basically any infectious complication. And I think we make another break here for further discussions.
I would have a couple of questions on PJP, but I guess firstly, Hannah should address the issue of CMV because she's really the expert in this field.
No.
And yeah,
I had a question about PGP also. But yeah, because I think it's one of the most important topic in the field of chronic kidney disease, rather than CMV, that there is a higher higher risk in transplant patients. So so comparing what we have in transplantation, I had some question about what we did in our unit regarding the mask and the risk of acquired PGP into your unit of immunocompromised host. For example, in our unit, mask is not recommended elsewhere than in our unit, but we keep it because we know that it could limit some viral or also fungal human-human transmission. And we know that PGP could be one of these fungal infections that could be transmitted from one patient to another. So I was wondering what you have chosen in your unit regarding the mask recommendation.
Yes, I think the mask recommendation for freshly transplanted individuals is certainly very, very important. We had that even before COVID, as you had, especially to prevent transmission of such diseases, but also, of course, influenza. We saw a couple of influenza outbreaks in our nephrology unit. But the problem is that the nurses are not getting vaccinated and then transmitted from one patient room basically to the next one. And that's certainly a big problem. And so I think for freshly transplanted patients, it's very important that they protect themselves even in their room. And I completely agree with you. And this has been nicely reported that there have been endemic outbreaks of PJB in nephrology wards, infecting patients. And of course, this might also drive the numbers we have seen in the initial testing trial, actually. Not only the genetic risk variant, but I would also guess that in China, maybe there was a transmission between different patients.
I had also a question when you mentioned that there is differences between PGP incidence in patient with lupus compared to patient with vasculitis, for example, because we know that lung involvement is most frequent in those cases. And so I was wondering if the literature about that really make the difference between PGP involvement versus the first autoimmune involvement in lung, because we also have this kind of problem with mTOR inhibitor use and PGP. Sometimes patients have both mTOR inhibitor and PGP, and so mTOR is thought to be a risk factor, but then we observe that it is feasible to make it independent one for the other to really know what is involved in the pathology of patients. So I was wondering, what do you think about that? Because sometimes also the tests in lung is PCR, and we know that is a very high sensitive test that is not always associated with disease. So, yeah.
I think for a single institution, it's difficult to assess the various frequencies and incidences. I mean, we are not a transplant center, but we had 5 or 6 cases of confirmed PGP cases following transplantation where no prophylaxis was given. And we took these patients back and they landed in our hospital and were severely ill. These weren't just positive patients, but they were clearly on ICU and needed ventilation. So I think transplantation is obviously a very strong risk factor. Anchor vasculitis is an issue. We see these patients and it's difficult to differentiate between flares and opportunistic infections. And looking at the literature, I was surprised that lupus, although you would anticipate that there was also a comparable risk, seems to be a lesser problem. Perhaps Prof. Anders can help us clearing this issue?
Yeah, I think in the COVID pandemic, we learned that many of the risk factors that were attributed in the beginning to the mortality risk later turned out to be CKD, actually. I mean, hypertension and others. So I think the transplant patient is the day before a dialysis patient. So is a immunocompromised dialysis patient that's completely different from, let's say, a young lady with lupus that has a more or less normal renal function, excretory kidney function. The ANCA vasculitis patient frequently is more on the CKD side. So maybe all this explains different risk because all of these get heavy immunosuppression, but the infectious risk is different. But obviously, if the transplantation is successful, then the kidney function rapidly improves, and then probably later the infectious risk is more related to the drugs being used, especially when this includes anti-lymphocyte, anti-sera, or others. But yeah, I think CKD is an important component, and there are a couple of ideas how that actually contributes to the immunosuppression. I think that's nothing we need to discuss here. We have nothing we can do about it, but as I mentioned before, maybe taking into consideration that CKD patients have a high risk of infections only because of CKD. It's the second most common cause of death in CKD patients. Even the DAPA-CKD trial has shown that once more. It was the second most common cause of death in the DAPA-CKD population. So, and this is without COVID, without immunosuppression, without anything.
Yeah, if I can add on here, so in vasculitis, PJP was a huge problem in the 1990s, but it's not on an individual basis. It's not a big issue any longer. When we did our first infection study, I was collecting 192 patients receiving rituximab, and there was basically one case with PJP. So this shows that with the modified immunosuppression, less steroids, again, you can definitely reduce the risk of it. That means that it's really on an individual basis. You need to consider risk factors, like you mentioned. Lung involvement certainly drives the risk. COPD drives the risk. CKD drives the risk. But in a young patient, let's say 20 years old, 25 years old with ANCA vasculitis, even though this patient would have CKD, I think the risk of PJP is quite low, honestly.
That's why the results of the testing, the original testing trial, were so surprising for me initially, because this is a single kidney disease, not multisystemic, and kidney function is normally better in IgA nephropathy when you consider immunosuppressive therapy, certainly CKD 2 and 3. So yeah, I still can't make this all fit together.
I'm a little bit concerned when we make the recommendations too complicated or too restrictive, that we may forget some patients who may really benefit from prophylaxis. This may not really be an issue in transplant or vasculitis centers like Bordeaux, Munich, or Innsbruck, but in more general centers for nephrology, my personal opinion would still be that we might keep prophylaxis as a kind of default strategy, and then on an individual base decide for an individual patient not to give prophylaxis. Because again, for those patients who develop PJP, it's really a life-threatening disease. Would you understand my concerns?
Yeah, may I just answer that? Yeah, it's a very easy answer. So it's not about PJP, but DMB-SMX is a great antibiotic prophylaxis to prevent other severe infections. When I did the before mentioned study, and so the results of the statistician came back, and she said there is a 70% reduction in severe infection rate when you give prophylaxis. I was really struck by the number, and I couldn't really believe it. We reported that. And luckily, you know, 2 other retrospective studies have shown the same thing. So what you do with DMB-SMX, especially in vasculitis, is you reduce the risk of severe infections significantly. And then we looked at the RAVE trial data. So RAVE, cyclophosphamide / azathioprine versus rituximab in the induction of remission in AAV. And we found the same picture. So a risk reduction if you use DMP-SMX as opposed to the other prophylactic measures like dapsone or dovacron, a risk reduction of around 75%, which means that DMP-SMX is a great drug actually to reduce severe infections, including BJP. But BJP is not so much a major issue, at least in our cohorts. Clearly, we need to look at more severely impaired kidney function. Bexivus is the best example here to see, what does it mean if the GFR is down at 20, not at 45, 50, as in general our AAV cohorts do have. So this is, of course, something we are very curious to look at and see what's the true incidence frequency of BJP in a more severely impaired kidney function population.
If we go for prophylaxis in patients who received rituximab, we know that the B cells are down for months, in some patients for years. So how long would we have to continue the prophylaxis? Should we measure B cells regularly and stop prophylaxis once the B cells are back in the circulation, or should we stop after 12 months? Are there any data to help us here?
No, of course not. And this is, of course, an issue. I put together a grant application trying to put together a trial looking at 6 months prophylaxis versus 24 months prophylaxis. But this is not sexy enough. Nobody's funding such a trial, although it's clinically absolutely relevant. And this is an issue in the medical society, of course. I do believe that once you have the steroids down, rituximab is quite a safe treatment. And then you don't need prophylaxis any longer. But looking at your individual patient again, so in Innsbruck, my patients are much more healthier. They do have a BMI below 30, the most of them. But looking back to the time in England, you have patients who are not exercising that much. And then, of course, it's increasing the risk of severe infections, and you would like to prolong the prophylaxis for a bit longer. So the argument here is clearly that you need to individualize here. But I think in general, once you have the steroids at 0, then you can stop it. Of course, so the second part you mentioned, CD19 counts and immunoglobulins, that's an issue. We know that with rituximab, the depletion of CD19 cells, even with a single course, can be up to 3-4 years or even longer. So that argues, and this concept is very prominent in transplantation, that the immunocompetence of the individual is completely different. CKD, for instance, also prolongs CD19 depletion. That's clear. So you can measure CD19, but for your individual patient, it doesn't really, help you a lot, to be honest.
I always thought that the infectious risk is related to the unspecific nature of the immunosuppressants we were using. This is not only steroids, this applies also to cyclophosphamide or even MMF. These are unspecific immunosuppressants. And I always thought if we move to biological drugs that hit specific targets, we could maintain or even increase efficacy, but reduce safety concerns because we do these precise microsurgical interventions in the immune system. But now you show us here the data with anifrolumab, and it seems that here you even increase the risk for specific infections. And maybe in this regard, the two examples are really important. So it seems that we are not going through blocking all the different cytokines. Even I think now secukinumab has been stopped for lupus nephritis, so IL-17. We don't go through all the individual cytokines, but it's now centering all around B cells. B-cell targeted therapies, and they seem to be very potent, but are associated with these infectious issues. And we have the new approval of anifrolumab, which is an interferon inhibitor, which is the key cytokine for antiviral host defense. And indeed, it comes with high rates of viral infection, especially in patients with lupus nephritis that obviously have more immunosuppression than patients with non-renal lupus, maybe because of still a lot of steroids being used in in lupus nephritis. So is it really needed that we look at each drug individually, because some of these drugs are really very specific, but then eliminate key factors of antiviral host defense, for example? And in comparison to anifrolumab, probably even MMF is less of a problem because it does a little bit everywhere, but anifrolumab is very potent on a key element of antiviral immunity. So means the story remains complicated, right?
Yeah, I think you made a very good point here. I guess 2 examples from a clinical perspective. Again, Ray, if rituximab considered more safe than cyclophosphamide, but then you have a serious infection in the 11 patients each, you know, the same infectious risk with rituximab versus cyclophosphamide. And when you look at the ARMS induction treatment, those receiving MMF in comparison to cyclophosphamide had a higher risk of a serious infection. So basically, it's pretty much the same risk across different treatments we are using. So basically, yes, you can probably lump everything together. Of course, there are some that potentiate the risk, but overall, I think the risk is high in all patients as we use a lot of steroids. And the steroids are, in my opinion, the main driver of infectious complications. I guess, as mentioned before, the concept of immunocompetence, and Hannah knows it ways better than we do, like measuring torquedinovirus, for instance, that's something which needs to be translated into, you know, kidney disease as well. And looking at DTV as a very good measure, how the immune system can potentially clear infections is certainly helpful to balance, you know, the risk of infection and the risk of serious relapses of these diseases. So I think these concepts might translate from transplantation to kidney disease at some stage, and they need to be implemented to actually highlight how the host immunocompetence is to clear infections. But this is, of course, everything is future here.
Can I ask you another question, Andreas? You have now the experience in ANCA vasculitis that you can reduce steroids and prevent infections with a specific complement intervention, avacopan. So doesn't that tingle in your fingers when you have now a patient with anti-GBM or a crescentic IgA nephropathy or other forms of rapid progressive GN, where you basically know there is a strong involvement of the complement system, but these patients had not been included in the trial, but you are kind of confident that you basically, the patient would have the same benefit from using avacopan and the same reduction of infectious risk you could probably achieve, but it's off-label. So how you feel about that?
So in Advocate, the serious infection rate was not significantly reduced. So it was around, I don't know, 15.5 versus 13.5. So a difference of 2%, which is clinically meaningful, but not significant. I agree with you that, you know, I think avacopan has the beauty that it can be probably used in most of the diseases we are talking about here. But for anti-GBM disease, I personally envisage that imlifidase will be the treatment we should use, because that's certainly clearing what causes the disease in the tissue and in the circulation. So I think that imlifidase is a much more stronger or potent treatment. But in a way, you know, combining imlifidase and then starting avacopan afterwards, that would be beautiful. And then reducing steroids immediately, because again, that's the driver of infections in those patients with anti-GBM disease as well. But this would be, you know, very nice experimental medicine study. But with both drugs being very expensive, I think and the disease very uncommon, it's very difficult to recruit.
I would like to ask Hannah one more question. So how comes, Hannah, that CM virus is so important in transplant patients and transplant medicine, and apparently does not play that major role outside transplantation? Is it just because we are more focused in transplant medicine?
It's not an easy question, but perhaps there is several points. I think the kind of activation of the virus is really different between transplant patient and non-transplant patient, because in one case it is most common that it's the reactivation of the own virus, of the virus of the host. And so we know that even with immunosuppressive drugs, it's easier to control. And for example, in transplant setting, the risk is higher in D plus R minus patient than in D plus R plus patient, and then in D minus R plus patient. So the D minus R plus patients, so the mirror of those in a non-transplant setting, is the lower risk population. So even in transplantation, we know that reactivation its own virus is less at risk than the other settings. So that's first, I think, first point. And the other, because we know that, for example, the mispresentation of the virus from the donor to the recipient could lead to higher risk of reactivation or of primo infection. We know that, for example, mismatch on HLA is an increased risk of CMV reactivation in D plus R plus patient, for example, which is obviously not the case in non-transplant patient. And the other argue perhaps is that in patient with autoimmune disease, the kind of immunosuppression is quite different, because in transplant patient, it's really the immunosuppressive drug really target the T cells, and we know that T cells are the main actor for CMV control, rather than in non-transplant patient, where we are discussing here B cell depleting therapy or other. That, so in my opinion, that could also lead to a point. And lastly, perhaps I mean, I don't know, because now in patients with autoimmune disease, we know that there are cumulative immunosuppressive drug, but perhaps also the cumulative immunosuppressive drug in transplant patient is quite different, because you have tacrolimus plus MMF plus steroid plus induction therapy. And we know that CMV infection is most frequent during the first year of transplantation because of this burden of immunosuppressive drug, which is not quite similar in patient with autoimmune disease. So that's the 3 points I see to explain the differences. But perhaps I'm sure I missed some other.
So I think all issues have been addressed. Thanks so much to the 4 of you for being with us tonight. And I think it's a good time of the year in late September to discuss infectious diseases, because we should now really in the next weeks remind our patients to undergo their annual flu shots, their other vaccines that we discussed. Thanks so much. And I'm looking forward to have Andreas back as co-moderator for our next NDT talk in 4 weeks or so, when we are still within autoimmune disease and when we will discuss SGLT2 inhibitors in autoimmune disease, another very important paper that has been published in NDT a few weeks ago. Thanks so much to the 4 of you. Good evening.
Thank you. Good evening.
Thank you.
Bye.